This is again going back to the prognostic factors in kidney cancer. And several groups, understood that even when you have disease like kidney cancer that has spread, even patient outcome, even without doing anything, the survival may be different because your prognosis depend on several risk factors. And based on a lot of research the past 15 years, we determined that several risk factors play an important role in this disease, such as the performance of a patient. Even if the cancer has spread to few organs, is not a lot of cancer. If I see someone in a wheelchair for something else, that patient may not be doing as well as another patient. Anemia, not because the patient is bleeding or not. The fact that it's anemia, is it a reflection of the inflammation created by the cancer? At this time, we really don't know. But it doesn't seem to be a good thing to have, at least in the early, when we stratify the patient early on. The disease interval. Now we know that patient who has, let's say, stage 2 kidney cancer resected, and the disease come back in 3 years, compared to a patient that presents from the get-go with metastases in the lung, in the liver. It's better to have a long disease-free interval. And there are several others that I use in my practice. Luckily, 80 to 85% of patients fall in the favorable and intermediate risk, meaning they have none of these risk factors or they have one or two. And very few falls in the poor risk patients group. But that's a way to stratify patients into different treatment because the trials were made, a lot of them based on this important stratification that takes into account what we call the natural history of the disease, even if it was metastatic kidney cancer. Also, we try to stratify the patient if they failed the prior treatment or not, and that's what we call refractory metastatic renal cell carcinoma. So are you de novo treating a patient, or this is a patient that has failed prior treatment? Untreated patient, this is what we call frontline treatment. This is the vocabulary we use. When the tumor progression, we use treatment refractory. We also, in practice, are trying to get away from that. You see it a lot in the literature. It's not the way to say refractory, meaning nothing gonna work. So this is why we're trying to call it second line, third line, or patient who failed first line therapy. But that's something that you may see, and you need to understand what it means. This doesn't mean the end of the road. What are the recently reported large trial, the last year or so, since the time that, let's say, pazopanib was approved? Well, we had an important study called the renal effective trial that was reported, I believe, in February or March this year at the Genitourinary Symposium in lovely Orlando. This was a phase 2 randomized trial that compared the standard Sutent dosing at 50 milligrams, 4 week on, 2 week off, to the continuous dosing. There was a lot of rationale, to use that. One rationale is that it is better tolerated, and we had some sporadic evidence. The other rationale is that maybe you shouldn't use 4 week on, 2 week off because the tumor rebounds in the 2 week off. It's better to inhibit it with a larger dose. Well, the result came that there was no difference found, and the conclusion that the 50 milligram dose continued to represent the standard. Having said so, in my practice and in other, we have a lot of patients doing very well in the 37.5 milligram. But when you take the whole population, and that was clinical trial about, and prove at the level of the whole population, is the 37.5 better? Is it better tolerated? Actually, it's as tolerated, it's not worse. It is more efficacious, actually it's not more efficacious. But that was an important trial that you don't see a lot because people are more interested, in testing new compounds. What other trial was reported at the same symposium? So a trial of frontline Nexavar versus AMG 386 trial was reported. David and myself were in the audience. This trial builds on sorafenib by adding this investigational compound, AMG from Amgen. The investigational compound inhibits angiopoietin-2. One of the things we're very, very interested in, and the group at the Farber, but also at Beth Israel with Mike Atkins have done a lot of work, is what predicts resistance to angiogenesis. There's a lot of animal models that show these drugs that inhibit the blood vessel that feed the tumor, these angiogenic inhibitors work well, but then you continue the drug, there is revascularization. So what happens? So maybe that angiogenesis is also driven by other factors than VEGF. Remember VEGF that Dr. Saylor talked about. And in fact, it's true. It's driven by many other factors, but the most important one is VEGF. So in practice, developing a drug that targets angiopoietin, which is another way how to inhibit the angiopoietin inhibitor, other mechanism of angiogenesis, is really reasonable. And what we found that adding first the treatment, the combination was not toxic, that's the first thing. In some patients it worked very well, the responses were higher, but if you look at one of the endpoints that was progression-free survival, meaning how much patients live and stay on therapy, there was no differences found. And interestingly, the activity of Nexivar in the first line that we learned from other studies that is around 5 to 6 months was surprisingly better on this trial, was around 8 to 9 months. So I came up and asked Dr. Rini the question, why is that? Well, what's happening? This is not what we're used to. And we don't have an answer. Could it be the design of the study? Could it be the fact that physicians are more familiar now with managing the side effects of Nexivar and Sutent and other, so that the patients stay more on treatment, and whenever the patient immediately complains of pain here, I send them to Lori or to the dermatologist. Let's start 5 times a week, 5 times a day, the cream here, please, as much as possible, you're doing it once a day, or once the blood pressure goes up, I'm more careful, or others, to start the blood pressure medication and to be always in touch so that I don't see someone with blood pressure of 220 2 months down the road. That could be a possibility, but it's impossible, to say it for sure. But to me, I think that's a possibility. Recently, 2 weeks ago, David, we were together in the big Chicago American Society of Clinical Oncology meeting, and the result of the ACCESS trial that some people were watching this were presented. This is a trial that compared axitinib, a drug that is similar to Sutent, inhibiting the VEGF receptor, to sorafenib after failing the first line of therapy. So people that fail Sutent, or fail a drug such as interleukin-2 or interferon. This is failing first-line treatment. Remember that interferon continue to be used in many countries, in Europe, in Eastern Europe, in fact, in some part of Western Europe, continue to be used in some part of Asia, and sometimes some part of Asia is first line in Japan and others. So people that fail the first line, independent what the first line is, there are some people that were on Toricel, 8%. Some people use Avastin, very few. We randomized those people, those patients, to have axitinib or Nexivar as second line. And axitinib did beat Nexivar. The primary endpoint was we call progression-free survival, meaning how many patients alive and on therapy, if you want. Although the difference was statistically significant, this p-value we always look at, it was really only 2 months difference in terms of progression-free survival. The response were higher, but at least from this trial we can say that axitinib did beat sorafenib, and perhaps this drug, based on this clinical trial, will be brought into patients as another, possibility and another, compendium and another drug to be used in the future. But of course, I would love to have seen 15 months versus 4.7. I think, to me, people trying to look compared to sorafenib seems to be the weakest, but there is some activity here, more than we thought. So what's next in large RCC clinical trial? I'm going to focus on the large trial. Well, one of the questions we tried, and I'm very interested in personally, better efficacy with decreased toxicity. If I can find a super Sutent that doesn't have, some toxicity, perhaps, that's great. And there are several series of phase 2 and trial in progress. Let me ask this, out of that, how many people have been on a clinical trial in this room? Well, let me tell you, if you look at some of the large databases from the government, overall, in advanced cancer in the United States of America, the #1 country in the world, the